I am delighted to be with you today for our closing plenary, taking care of our abuelitos. No one is able to prepare you when a loved one is unable to recall who you are. Setting all that you are aside and caring for those that cared for you during the most pivotal stages of your life. No one will ever truly understand what it is to have a family member fighting to stay present until you get that unfortunate call with a diagnosis that something is wrong. In our culture, we tend to put our health aside. Mental health, above all, and most frequently, the unimaginable financial cost prompting us to put it off a little while longer. And repeating the words, pues ya estoy viejo, mijo. A great appreciation is given to those seeking to aid our abuelitos, and for opportunities such as these, as the summit, prompting us to learn from one another and seek company in the efforts to taking care of the pillars of our community. On behalf of CHCI, I would like to thank our sponsors for their generous support of this session. AltoMed, American Association of Retired Persons, Elevance Health. It is now my honor to introduce welcoming remarks from the chair of this panel, Congresswoman Sylvia Garcia. Congresswoman Garcia was elected to the U.S. House of Representatives in 2018, becoming the first Latina ever to represent Texas' 29th Congressional District. She serves on the House Financial Services Committee. During her first year in Congress, she played a critical role in the impeachment investigation against President Donald Trump. She is also a member of the Congressional Pro-Choice Caucus, co-chair Congressional Caucus on Homelessness, Equality Caucus, vice chair of the Poverty Task Force, Congressional Diabetes Caucus, and Congressional Mental Health Caucus, among others. Please welcome Congresswoman Sylvia Garcia.
Thank you so much, and thank you, Jose, for that great introduction. And first, great panel. Don't we have a great panel? And it's good to see everybody here today. It's, talking about our abuelitos, I can't think of a better topic, quite frankly, on such a beautiful day, because as he said, many of us will face that time where we're going to be told, no, pues tu abuelita ya no puede escuchar. No, pues ya tu abuelito no te puede conocer. No, tu abuelita. We hear that and we panic, right? Because this is the grandparents that we've known since we were little. So this is a very, very timely topic. And for me, it's one that is personal only because my first degree is in social work. And my first job, and I did for, I guess, 5 years, was a geriatric social worker. So I worked with, back then, we would just call them ancianitos, we used to call them seniors, but now I think I like the word abuelitos or abuelitas. So I've done a lot of work in this area as a social worker and later as a legal aid lawyer. And even today, we have a very robust senior program where we work with about 35 to 40 of our senior programs throughout our district. And the first town hall meeting I had this session was a Medicare, Medicaid senior town hall meeting. And you would think that abuelitas today would not come to an in-person meeting, but no, they were there. And they were there because they know that Medicare, Medicaid, many of our senior programs are under attack. And you talk about taking away their Social Security, their Medicare, or their SNAP program, and they're there. They're going to be there guarding that just like they guarded us as their grandbabies. There's nothing like trying to take a grandbaby from a grandma. You don't get in the middle of that one. So I think it's for many of our seniors, now abuelitas, when it comes to health care, it's non-negotiable. Stay away from that. And in my district, it's particularly so because for us, we're 77% Latino in my district. And we have the distinction of having the highest number of uninsured people of any district in the country. So out of 435, you're looking at number one in a space where we don't want to be number one. So the programs that we have are programs that we need to protect. And if you look at what the McCarthy has laid out in his demands in exchange for working on the debt limit, the things that he's looking at will hurt our abuelitos. It will hurt our abuelitas because he's looking at making cuts to Medicaid and healthcare for seniors, veterans, and working class families. So that's a lot of people in my district. So I think when he keeps talking about putting caps, it really is cuts. It really is cuts. And we should not allow anyone to try to deceive us on what that really means. So I think as we move forward, we need to be very cognizant of the fact that it's more than just making sure that they can go to a senior program to get a meal. It's more than just making sure that you can help them go see the doctor. It's more than just you making sure that, you get them something for Mother's Day that's coming up. It's about protecting what they have. It's about protecting those resources and the access to those resources. Because quite frankly, if we don't do that, then who is? Healthcare, in my mind, is a human right. We should make it as accessible to everyone as possible, not impose restrictions because of who you are or your age or your disability, your immigration status, your housing status. It should just be accessible for everyone. 4 in 10 people in Houston, in Texas, are in the coverage gap. Those are the ones that are the toughest to try to do something for because Texas does not have Medicaid expansion. That's why the numbers for me, being the number one, are so high. Because unless people in my district have private insurance, and many, many, many don't, or some program insurance like either Veterans CHIP program, Medicaid, or Medicare, then they're just plain out of luck. So we work real hard to try to get the state of Texas to expand Medicaid, but also work twice as hard to try to get dollars for all our FQHCs to make sure that they have the funding that they need to be able to meet the demands in my district. And you compound that with poverty rates, you compound that with language barriers. It's a difficult task. So ever since I've been in the state senate, ever since I've been a county commissioner, for me, healthcare is a priority, period. And then you factor in what we need to do for our seniors, well, then I'm going to be there to take care of them. Did that as a social worker, do it now. So I think for me, it's important that we continue to do that. I know I filed last time a bill called the Elder Abuse Protection Act, which got out of committee, but fortunately did not make it through to the Senate, that would help with reporting and tracking of elder abuse, because quite frankly, it does happen. It happens. And we need to continue to be vigilant about making sure that when we take care of our seniors, that we're taking care of all of it. So I hope to make sure that we continue to work in this arena and look to make sure that our seniors have the financial support that they need, the emotional support, the mental health support, and everything that they can to make sure that they can spend their remaining years however they want. If we sent them a stimulus check and they decided to give it all to one of their grandbabies because that's what made them happy, to make their grandbaby happy, that was fine with us. If they decide to use any money that we send them instead to buy themselves a treat, let them do that. We've got to make sure that we focus on their good life. Not what I wanted them to do as a social worker, not what the tia wants them to do or what the daughter wants them to do, and always count them as a blessing and never a burden. Because our abuelitos and abuelitas are truly a blessing to all of us. So keep your eyes open and vigilant about all the things that will be under attack. And when it comes to abuelitos, remember, you will have to speak up for them. And you need to do that by calling, writing, texting, whatever your mode of communication is, to make sure that their voices are heard through you. You are going to be their best advocates. So I urge you to do that, and good luck with the rest of your forum. It's been a pleasure being with you here today. Thank you.
Thank you, Congresswoman, for all that you do, most in particular for all that you do for our abuelitos. Thank you for your service. It is now my pleasure to introduce today's moderator, and apologies if I butcher the last name.
You're not the first.
Vivian Nava Schellinger. Did I do great? Okay. She is an equity and aging advocate and the former director of the National Council on Aging. During her tenure there, she led the organization's engagement with national and community partners in give me 1 second. During her tenure there, she led the organization's engagement with national and community partners to include the Equity in Aging Collaborative, a coalition advocating for the Elder Index, an alternative measure of financial adequacy as people age. Throughout her career, she has led efforts to increase the safety, acceptance, and access to programs and services for hardly reached communities across the lifespan. Please give a warm welcome to our moderator.
That name, growing up in a Latino family and appreciating our differences in the way in which we participate in our community through language. So thank you for that. But anyway, good afternoon. My name is Vivian Nava Schellinger, and I'm very happy to be here today to really lead this dynamic discussion. Thank you again to Congresswoman Garcia for your opening remarks and your commitment to healthcare concerns and to our abuelitos. And thank you to CHCI for hosting this conversation with an extraordinary panel of experts. You know, before we introduce or have our panel introduce themselves as I go down the line, I wanted to talk a little bit about why we're here today, taking care of our abuelitos. You know, a couple of years ago, I actually wrote a piece for the National Council on Aging on my own caregiving experience. It was in honor of Hispanic Heritage Month, and it was to honor Hispanic and Latinx caregivers. Within that article, I identified that at 15 years old, when I would come home from off-campus lunch to take care of my grandmother, I really didn't know that I was caregiving. It wasn't until after the fact, years later, that I realized that between my mom and her sandwich generation life, my mother, myself, and then later, much later, after getting off of a wait list that we all know too well, we were given some home health aid and care. And so what I realized was that I was part of a caregiving team. But at the time, it's just the way that we show love. For me, it was just what you did. And there was really no question about it. So, I do want to take some time as we discuss today to kind of delve into those issues, whether it's caregiving, whether it's workplace flexibility and labor law and policies that allowed my mother to be able to take time to care for her mother. And then now myself, thinking about some of the care that I give to my parents in their older age, whether virtually or across the miles. I know probably every single one of you is either experiencing that now, has experienced that, or will. And so I'm really excited to be here today. This is personal for me. I'm sure it's personal for all of us. I know that each one of us in this room probably has a memory or some sort of reflection point from our abuelitos and what we've learned. But let's talk a little bit about Latino older adults. You'll hear about statistics, you'll hear statistics today, and we really can't continue our conversation without acknowledging the larger context, as you have earlier today in some of your sessions around COVID-19 and how it impacted not just Latino older adults or abuelitos, but families, entire households. More than 39% of Latino families have depleted their savings to pay for healthcare costs associated with either long COVID or kind of the aftermath of that. The pandemic diminished the Latino mortality advantage among older adults as well. And so I want to really talk about that with our esteemed panelists today and talk about some of the lessons learned, if that's what we'd like to call them, but also what does that mean now? What does that mean moving forward? And how do we address some of these issues that we know are present while also understanding that it is a sense of duty to take care of our elders in our community? But first, let's welcome our panelists. I'd like to welcome Orlando Gonzalez, President, MMM Holdings and Elevance Health. Second, I'd like to welcome Paloma Izquierdo Hernandez, President and Chief Operating Officer, Urban Health Plan. And next, we have Lisa Ruiz Vangelatos, Social Work Manager, Senior Care Services, Ultimate Health Services. And last but not least, welcome Dianza Valencia, Director, Government Affairs, Family and Caregiving, AARP. Welcome to our panelists. So I want to go ahead and start with a question, a little off script, so apologies, Kim, but I think it's pretty appropriate just to learn a little bit more about your panelists today. We're talking about taking care of our abuelitos. We're talking about this sense of duty. Can each one of you just share kind of a quick kind of rapid response format? Can you just share maybe what taking care of your abuelitos means to you? And we can start with Orlando.
Yeah, good afternoon, everyone. Very pleased to be here, particularly surrounded by this, panel of very successful women. I feel honored. and Vivian, it's what the sort of question that you pose is very interesting. We at Elevance in Puerto Rico manage about 300,000 seniors in our MA program. And in the States, more than 2 million of those seniors, abuelitos that we take care throughout the nation. And it's a big responsibility. I mean, when you think about our topic today, taking care of abuelitos sounds simple, but in reality, it's a big responsibility, particularly because we're dealing with the most vulnerable population. We're dealing with the people that struggles every day to make a living, that most of them depends on a social security check, and they're impacted by, the post-COVID situation, but also with the inflation. They don't have anywhere to go to get more money to deal with inflation and the struggle sometimes that they have to go through in order to access sometimes what we call social determinants, which is basically their need for transportation, their need for getting groceries. And at Elevance, we take that very seriously. And when we have implemented significant, and various programs to address that I'll be happy to share later on some of the details of the things we're doing to address those. But it's a big responsibility for sure.
Hi, everyone. Thanks for this opportunity to be here. I want to thank my panelists, and I want to thank CHCI for inviting me. So I'm this Chief Executive Officer of Urban Health Plan. It's a federally qualified community health center, which we'll talk a little bit more about. I know lots of people have referenced FQHCs, and that's what we are. But part of what we do is, yes, we serve all of life cycles, but at Urban, we have a very specific program for our older adults, and we call it our Center for Healthy Aging, which I'll tell you about later. And it was really born out of my own personal experience, talk about personal experiences, because my parents were older, and my father, and I'm a buena Latina that cries really easily, so I'll put it out there. But my dad founded our organization, and my dad ended up with Parkinson's and very disabled. And so I knew as a caregiver how difficult it was to navigate the system for my father. And with that, I recognized if I have difficulty navigating the system, what happens to our patients? And how do we build a system around our patients so that they don't have to navigate as difficult as I had, which for them would be astronomical. So through that, we've built a whole continuum of services that I'm very, very proud of. But I think taking care of our abuelitos and our abuelitas, and you know, my dad had Parkinson's, of great mind till the very end. He passed away in 2020. My mom has dementia. And so here I have these two situations, right, which sometimes we face. And I remember being asked, do you think it's better to have poor physical health or poor mental health? And of course, you don't have any clue until you're faced with the situation. And here I am. But taking care of them, taking care of our elderly patients, to me, is really making sure that all those social drivers of health, that their food insecurity, that their housing, that the fact that they don't have to go up and down the stairs to get their medication, that we're able to do home visits, that we're able to meet them where their needs are, is really satisfying and very gratifying. Very fortunate to have a team of all Spanish-speaking professionals that serve those patients. And yeah, I get so much pride out of seeing them in their own waiting room with their own paintings, with their own self-expression, and being able to know that they trust us and that they know that they could get the very best from us, because there really is limited things that we won't do. Somebody will come to me and say, well, could we get them an air conditioner? Yeah, how much is an air conditioner? $300. That's not a big deal. Get them the air conditioner. And I think being able to be in a position like that, that enables you to really meet people where they are, is just a wonderful place to be. I'm glad that my experiences have brought me to really understand the level of care that our elderly really have and that they really deserve.
Hi, everybody. Such an honor to be here. Thank you. I work with Ultimate Health Services. Ultimate, also probably the biggest, one of the biggest FQHCs in California. And one of the main business lines that we have at Ultimate is called a PACE program, Program of All-Inclusive Care for the Elderly. I know one just opened up here in DC. I read recently. Yeah, good news. It's a great program, and I think, you know, building on what Paloma and Orlando said in regards to social determinants of health, that's what the PACE program is all about. It's an integrated, comprehensive system of services that addresses all the parts of someone's life, right? So these are individuals, we call them participants, with chronic medical conditions, 3-4 different diagnoses, right? Multiple medications. They are individuals who meet criteria for nursing home level of care. So they have severe deficits in activities of daily living and need help with a lot of different things. But rather than moving into an institution, they're choosing to stay in the community and receive that level of support from a program like ours, like the PACE program. So it's really integrated, very comprehensive. And I've been there about 10 years. You know, I grew up Cuban immigrant parents. You know, my grandmother was the one taking care of us while they had their 2 and 3 jobs, you know, to make a living. And so as a trained social worker, I always thought that I'd work with little kids because they're cute. And then I realized they're not that cute. I'd rather when they start talking and arguing. So, you know, working now with the geriatric population for all these years has just, you know, lit this fire within me, just thinking about how lucky we were, my grandmother was, to have us, you know, supporting her and providing whatever she needed. And we serve so many families in the PACE program, this is out in California, that don't have those supports, right? They're lucky if they have, you know, daughters, nieces, granddaughters, sons that can help them. But the PACE program really sets it up so that we look at every aspect of their lives. So it's not just primary medical care, right? There's an understanding that we've got to look at diet and mobility and exercise and social and emotional well-being and cognitive skills. And all of that matters to help someone stay as safe as possible, as healthy as possible in their community for as long as possible, and to avoid institutional care. So the PACE program is really a value-based program. It's not fee-for-service, it's fully capitated, it's risk-adjusted, so there's a lot of flexibility in the way we can deliver services, while also being cost-effective, right, in serving folks with very chronic, complex needs. So I'll talk a little bit more about the program, but thanks again for having me here. It's a pleasure to be with you all.
Well, hello everyone. Dianza Valencia with AARP. AARP is proud to be a sponsor of this panel and want to thank CHCI for this opportunity. At AARP, we're the largest membership organization in the country representing 50 plus. So taking care of our abuelitos is what we do at AARP. But to your question, what is it at a personal level? I mean, this is extremely personal, and part of my journey to work at AARP came as my journey as not only a mother, but also a family caregiver. I was the family caregiver for my mother who had a full liver transplant. I actually had to leave the workforce. I lived some of the issues we're talking about today, and taking care of our abuelitos is what we do at AARP. This is what we take very seriously. We are laser focused on supporting unpaid family caregivers and their needs, and we are on a mission to make sure that their voice is heard and they come out of the shadows and they get what they need to take care of all of our loved ones.
So you've heard today a couple of just kind of personal anecdotes of probably why people on this panel are doing the things that they're doing, and why it's personal to all of us. But one thing that I wanted to share before we dived into talking a little bit more about caregiving, and we'll start with you, Dianza. But a mentor once told me that aging, may not be your issue now, but one day, if you're lucky, it will be. And really, that hasn't rung as true as it has for me after, all of us have lived through the last 3 years of the pandemic and seen that older adults were impacted the most, and more specifically, Latino and Latinx, Hispanic older adults. And, if aging really isn't your issue now, one day it will be. And I hope that resonates with you as well. And so let's talk a little bit about kind of that personal, again, just staying with this theme of how this is personal to us. Caregiving. Can you tell me, Dianza, a little bit about what kind of the average Latino caregiver looks like, and some statistics and really paint that picture for us?
Absolutely. So I wanted to start off. So right now, someone turning 65 years old, there is a 70% chance that you're going to need a caregiver in your remaining years. At AARP, we recognize that caregivers are, we call them the invisible backbone to our care system, or our care economy, and our long-term care system. Caregivers are at the heart of what we're talking about here. And so we're not only talking about our abuelitos, we're talking about those that are going to provide the care. So a little bit, I think I'll just do a sort of a snapshot of caregiving in the United States, and then we can drill down a little bit in terms of Latino caregivers. So right now there's approximately 53 million caregivers of adults in the United States. So we're not talking just about mothers and children. 9 million of them are Latino family caregivers. And of that 9 million, 7 million Latino family caregivers are taking care of a loved one that are 50 and older. So that's really what we're concerned with at AARP, who's taking care of our members. They're providing an estimated, and I say this with a B, $600 billion in economic value and hours of unpaid care that we're giving to our loved ones. Without our unpaid family caregivers that are taking care of folks at home, we would not have a system. In terms of overall trends of family caregivers, we know that in about 11 years, adults 65 and older are going to be outnumbering those that are 18 and younger. So where are our caregivers going to come from? We've got a declining birth rate in this country. People are waiting longer to have kids. It's affecting who's going to be able to be a caregiver in this country. We've got increased racial and ethnic diversity in who's actually providing care in terms of who the typical caregiver is. It's not one ethnic group. And we've also been affected, like you mentioned earlier, by the COVID-19 pandemic and the direct care workforce shortage. So there's not a lot of people providing care. We also are finding that current family caregivers are actually being forced to do sort of more intense medical tasks related to their family caregiving. For example, wound care, or things that typically nurses would do. Now you have to be able to do those things in order to be a family caregiver. In terms of Latinos and Latino family caregivers, they tend to be younger in general, and they tend to be what we call sandwich caregivers, which is that they have a young one, someone 18 and younger living at home, and also have an older family member that they're caring for. They tend to be younger. When I say younger, I'm Gen X, but actually we're seeing now at AARP that they're millennial caregivers, and even Gen Zers are being put in the position to do family caregiving within their home. Like I said, they're doing the more intense caregiving. And we're talking about, I've heard it on multiple panels today, they're less likely to have health insurance. They're less likely to know where and how to reach out for resources and help. But something you said earlier, this to me, these are the two most unique things about Latino caregivers. One is that they don't self-identify as family caregivers. It's just what we do. So actually putting us in a box and saying these are supports for family caregivers, I never self-identified. That was my mother. That's just what we do. And I think that is an inherent challenge that we need to sort of look at. Why are we not self-identifying? And how can we, in order to just better increase access to supports and peer-to-peer networks and all the things that exist out there, we need to recognize that we're actually doing something and we're playing an integral role in the long-term care system in this country. The other unique thing about Latino family caregivers, and I think this is really special, they tend to get a sense of purpose and meaning out of family caregiving. It isn't a responsibility, is it? Oh, I'm the one who had to take care of mom. No, there's meaning in it. For all of us here, we could tear up a little bit thinking about our loved ones, our abuelitos, because it has meaning. It's a cultural value, and I think that that's very unique. And I think it's important in how we look at supporting our family caregivers and the needs that they have moving forward, and how they're sort of special and why our community is a little bit unique.
Thank you, Dianza. You brought up the issue of, it's a complex issue. It isn't as simple as we talk about it often, and it isn't as simple as maybe often policymakers want to couch the issue. It's very complex. It's related to economic security. It's related to workforce and labor issues. And so I want to talk a little bit about that economic security part. And so Orlando, I'd like to pivot to you a bit and talk about some of the considerations related to facilities as people age, and thinking about some of those common economic issues. Mm-hmm. And what should families and abuelitos, what should we consider when taking care?
No, very, very important topic. What I'm going to do, Vivian, is to frame that discussion, just to bring some data to the audience. Imagine a place in the United States where 43% of the population lives on the federal poverty level, where basically people have no resources to pay for transportation or for groceries, where the reimbursements that we get for Medicare or Medicaid are much lower than any other place in the nation. In the case of Medicare, 39% lower than the average. In the case of Medicaid, 25% of what people get in the continental United States. I'm talking about Puerto Rico. In addition to that, physicians leaving because they're more competitive compensation package in the states. So they're leaving. And many of the caregivers leaving because they're in the working class and they're coming to the States to work, leaving the seniors by themselves on the island. So that's the situation that we face every day, and creates significant challenges for entities like ours to be able to manage their health needs. So of course at some point we were thinking, should we get into the social aspects of our business? Because we are a healthcare, we're supposed to be a health plan. We're supposed to cover medication, hospital, physicians. But how, if we don't do it, who's going to be taking care of those aspects, those socio-economic aspects that are so important for this population? So we have developed programs across the year. We have what we call Members Club, which is basically places where members go every day. We pick them up at their house. We take them to these places and we give them activities, and they can interact among others, because we're talking about mental health, and loneliness is probably the most important aspect of mental health that we need to definitely address. Transportation for sure, food, healthy food, have access to healthy food for sure. So those are the kind of things that we have to do in order to address those needs. Congresswoman Garcia was talking about the threats that we're facing right now in terms of potential cuts in the reimbursement for Medicare. If those really materialize the way they're shaping, plans and the system will have no choice but to cut supplemental benefits that are so critical, so important for the members to have access to some of their needs and address those economic gaps that they're facing. So it's a very complex situation, but requires a lot of collaboration and working together. We have partnered with our physician group. We have partnered with other organizations throughout the community to address those needs. And in the case of the caregivers, we actually have a program that is basically navigates caregivers through the system because it's very, very complex. And also to address those that have left the island, we have electronic, basically, connectivity to keep them informed as to what's going on with their loved ones. So through our mobile apps, our caregivers have access to everything that's going on with their members. So they can log in and they can check status of their visits, and they can check everything, outcomes and everything, of course, with PHI and everything, to comply with HIPAA and everything. But this is the kind of thing that we as a plan have been forced to do in order to address those socioeconomic needs that are so important for the members. So in reality, it takes, when you think about it, it takes everyone to think outside the box and be creative and don't get, basically focus on what you're supposed to do, but focus on what you have to do because the members needs to get, those access to services. So it's very challenging, but, we have specific examples that can be done.
Thank you so much for that. You mentioned focusing, I like that. You mentioned focusing on not just what you have to do, but what you need to do.
Right.
So that makes me think a little bit about collective action and community engagement and what that means for our community in particular and our communities within our larger community. And so I wanted to actually ask Paloma to tell us a little bit about FQHCs and really the community health centers and what kind of services are provided in community health centers. How is that different than potentially nursing homes or other facilities? And what is that community-centric framework?
Sure. So I don't know how many of you are familiar with community health centers, but I do want to add that I am the incoming chair of the National Association for Community Health Centers, the second Latina in 50 years. So I say that because that's amazing that an organization has been there for 50 years and it's only had 2 Latinas as its chair. And really, that's why I want to do it, just to set that example so that others that come after me know that if I could do it. But community health centers there are 1,400 community health centers in this country. We comprise the largest primary care network in the country. And so we are connected through the federal government that administers grants that we receive to make sure that people who don't have any insurance or are underinsured can be seen irrespective of their ability to pay. We're 1,400 of us with 14,000 sites. Rural, migrant workers, urban, large, small. Altamed is a huge FQHC. And then we have some that are very small. And so the saying is, if you've seen one FQHC, you've seen one FQHC. And that's the truth. We provide services from cradle to grave and really focused around preventive care and primary care. And then we add, right? So in our health center, we have a lot of medical subspecialties we provide. So our patients are able to get podiatry and gastro and endocrine and the whole array. We must have about 21 different subspecialties. And then there's some others that provide a lot of dental care. So The bulk of the health centers, I would say, are a combination of primary care mostly, followed by oral health, behavioral health, and then we have vision care, and some of us have physical therapy. So we're as comprehensive as we would like to be, and as each one decides. What's very unique about FQHCs is that, and I keep saying FQHCs, and we really are community health centers, and that FQHC has become, it's a legal term that just has kind of stuck, so now we're FQHCs, but we really are community health centers. But one of the things that makes us very unique is that our board of directors, 51% of our board have to be patients of the health center. So if you think about that, it's pretty unique and it's pretty cool. The fact that your patients are actually the ones who are in charge of the governance structure, approving your budget, hiring and firing the CEO. And so it's very, very grassroots, very community-oriented. And that's who we are. We're really part of those communities where we all reside. In COVID, the response that we had in vaccinating and in testing was phenomenal, to the point that we just got a whole nother bunch of money because the federal government realized that the work that the community health centers could do was real, because we were right grassroots, right in those communities. We are very different than nursing homes, of course. We strive always to keep people healthy and to keep them well. And we're even different in that aspect than the hospitals. Right? So the hospitals take care of sick people, and we try really, really hard not to make them sick. And I think in addition, community health centers also provide a whole bunch of services that address social drivers. So whether we have food pantries, we happen to have a workforce development unit, transportation, translation, social services, nutrition, health education, community health workers are part of who we are. So we really use those services to cover the gap between when the patient is seen by the doctor and what happens when they go home. So we always say they see the doctor, everything's perfect, and then they go home and all hell breaks loose, right? And so what we try to do is gap that with additional services that really support the patient. And that's what enables us to have the kind of outcomes and the kind of cost savings that we've had to the healthcare system. We have been able to really save money every year in the kind of care that we provide. I will say that the elderly population, the health centers as a whole see 30 million people in this country. 1 out of 11 Americans is serviced by a community health center. We have a bunch of them in Puerto Rico.
That's true.
We've had in the elderly population a growth of 147% in 10 years. They now comprise 11% of the population that we serve. So we all recognize the importance of taking care of older Americans, and we're very, it fits right within the model that we all practice.
Thank you. I think a natural transition would be to talk a little bit about PACE programs. I know that I was honored to be able to visit a PACE program in California and learn a little bit more about what they mean to the community, what they mean to the individual, and I do believe what they could mean to our community more broadly. Can you tell us a little bit about PACE programs?
Sure. So again, it stands for a program of all-inclusive care for the elderly. And the main philosophy is keeping people out of custodial care, out of institutional care. So, there's certain criteria: 55 and older, meet nursing home level of care, you have to be able to live safely in the community. Essentially, the PACE program provides that 24/7 level of care to the participants in their home, right? But again, in an integrated, comprehensive manner. And so at the core of the PACE program is the interdisciplinary team model, IDT, you might hear it referred to, where you have 11 members, 8 of them professional clinical disciplines, that work to assess needs, evaluate, and then, again, based on that capitation, full risk model that we have, determine which services are really necessary for someone to keep them at home safe and healthy for as long as possible, right? And avoid custodial care. And so occupational therapy, physical therapy, registered nurse, primary care, specialty care, we provide transportation, medication, we have pharmacies or dispensaries at our day centers, there's adult day center activity for the socialization and the recreation piece of it. We at Altamed during the pandemic actually didn't shut down any of our PACE programs, they remained open. And while we asked most of the participants to stay home, there were a number that would come to the centers because they were safer there than at home, right? Because family members had to go to work or had to, do different things during the pandemic, so we stayed open. We actually opened 3 centers during the pandemic. Still can't believe it. And they're thriving now, or just increasing attendance, participants are coming back, and typically they attend the centers 2 or 3 days a week. And again, they see their doctor every 6 weeks. They meet with a social worker, with an RN, with whoever they need to meet with, depending on what their individualized care plan is all about. And I want to talk about the piece in terms of the integration with the mental health and the behavioral health, as we call it, because that's such an important part, especially as it relates to abuelitos, right? Because I know in my house, you couldn't talk about seeing a therapist, right? Yo no estoy loco, it's that sort of thing, right? And so we've had to do a lot of work to help educate our abuelitos, our parents, and their families around what that means. We're so lucky that last year we actually brought on a chaplain. And so now we have that spiritual support, and we feel like that's an easier avenue sometimes for our abuelitos to accept behavioral health support services than seeing a therapist or a psychiatrist, right? Which seems kind of labeling. So the PACE program, when you compare our population, so it's a nursing home population, right? These are folks that could be living in a nursing home. In comparison, in terms of COVID rates, COVID, level of illness and levels of death was 1/3 the rate of the regular nursing home population. Imagine, that's really crazy because it is a preventive model. It really is. And the folks that were getting COVID are our population, but because we anticipate, we've been ahead, it's been preventative. It's, again, that whole person model and really values-based, where we take into consideration, to the Congresswoman's point, what they feel is important, right? So we diagnose, we acknowledge what the medical problems are, but then we have that conversation, we put them at the center of the care plan. What is it that you need? What's gonna keep you safe and healthy at home in your community, right? And that's gonna mean different things to different people. And so we're really excited with COVID as well. We've been able to explore a lot of different technology avenues for service delivery, right? With people staying at home, how are we going to serve them other than just your home-based visits? A lot of things that we're exploring out there for caregivers as well. There are different devices, iPad-like devices that can provide education and for communication. We just piloted a VR. I just saw some of our abuelitos with the little devices on their heads, kind of looking all around. Again, to the point about social isolation, right? With COVID, a lot of people have wanted to stay home. They're afraid to come back to the center. So what can we do to still, promote, the inclusion and socializing and things like that? So I think technology is a really important piece too that we have to invest in and think about. And just, again, the integration. Mental health, primary medical care, you can't separate them, right? They've got to go together if we're going to look at the whole person.
Thank you, Lisa. Mm-hmm. So I know we have about 5 minutes before we move on to Q&A, but I wanted to ask a question of the entire panel, and we can go in reverse order, Orlando, so you're not always the first to answer. And be ready. But we talk a lot about what we've been through in the last 3 years and our various industries and organizations, and really it makes me think of the saying, when you know better, you do better. And so how are each one of you essentially doing better to serve our abuelitos through your respective organizations, your leadership, your commitment to some of the issues that we've already heard here, investing in caregiving supports, mental health and wellness, culturally responsive care, and then framing it around the need for strengthening economic security. So, whoever would like to go first, but how are you doing better?
Well, I think, COVID, as many crises, push people to think differently. And I think, part of what we experience is precisely that. We look for ways to serve differently. We look for ways to reinvent ourselves, to continue, to serve our members. Because, healthcare is something that is not a Monday through Friday thing. It's not an 8 to 5 thing. It's a 24/7, 365 days a year. You always could be exposed to healthcare. So I think COVID, pushed us to think differently. And you saw a bunch of programs that were launched like right away because, that's usually what crisis does.
And I'll jump in. I think COVID exposed a lot of the cracks in the system. And it really, for us at AARP, it really, sort of reinforced what we needed to be doing to support family caregivers. And at AARP, I think all of you on your seats have a Prepare to Care guide that we put out. We have a number of resources at AARP that we have been pushing out. And I wanted to sort of back up a little bit to Orlando's point that most family caregivers, about 60% of them are working. And because Latino family caregivers are younger, that means it's not a situation where you're retired and you can care for your loved one. It means you're having to take time off of work in order to provide the caregiving, to take mom or, to the doctor. And so having resources and even knowing what that is, I think is really, really important. At AARP, it's actually very state-specific, sort of what's available to you as a family caregiver. So we have links on our website to very state-specific resources. We have Prepare to Care guides, full guides that family caregivers can use, because we know that these steps are critical in caring for our loved ones. We also, and you were talking about training, and I mean, these systems, they're in place. Well, they can't do it all. We know that these systems and these types of programs are there and they're wonderful, but they can't do it all. Ultimately, it will fall on the family members in order to do that. So our family members need to be trained. So we actually have a number of training videos so we can help family caregivers. They're called Home Alone, the Home Alone Alliance videos. They're just how-to videos on how to do caregiving. We have our Prepare to Care guides, and we also do a lot of sort of financial pre-planning. This is an uncomfortable area. It's hard to have these conversations about what aging looks like, what care is going to look like. Where are you going to be going? And so we're trying to help navigate that through AARP and some of the resources.
I want to follow up on that because you and I were talking on a call about advanced life planning. That's another area that we talk about that's so challenging, right, with our families. And so I know through the PACE program, that's a big job of the social workers where, what is advanced life planning? We work a lot with the providers, especially for those families and participants that are in palliative care or receiving hospice care in terms of talking about medical decision-making and the importance of that and how challenging it can be at the end of life. And just, all that entails. And I think part of that is the cultural competence and the cultural humility piece of it, really understanding. We happen to serve a great majority of immigrant folks through our programs because of where the counties that we serve. And so we have found that we've had to be creative and really think about how we introduce services and how we explain services so that they're, understood and accepted. And we found that really it's got to be from a trauma-informed perspective, where we're looking at and asking, instead of what's wrong with you, is what happened to you, understanding where someone came from and, their family dynamics and what is impacting their decision-making in the here and now, right? And how they attend to their own health and what their expectations for us and the way that we care for them. So that cultural competence is really important in that integration of services. At our program, a little over 60% of our participants have a major depressive disorder diagnosis. About 40% have dementia, and then some other, anxieties up there, substance use disorder. But again, many times folks are coming to us at the age of 75, 80, 85, and we diagnose them, right? Because we start talking to them and asking them the questions, and then we can get the right services in place for them. So asking those questions from a trauma-informed perspective, spending time, integrating services. There's no getting around it. It's the only way to keep our abuelitos healthy and safe for as long as possible. And I just want to say that the PACE model, there's also, in addition to those COVID statistics, with the PACE model, there's definitely a much lower incidence of avoidable hospitalizations and a much lower incidence of ER visits because of the preventative nature of the program.
So for us, COVID was, like for everyone, really crazy, right? And we saw our centers just empty out. And we had to furlough 250 people because there were no patients coming in. And so what we quickly did was you do things because you have to do them. And then after you do them, you kind of realize, that wasn't so bad. That was a pretty good idea, right? So we started outreaching to our abuelitos and abuelitas, and we started picking like uncontrolled diabetics, uncontrolled hypertensives, making sure that they had their medication, arranging for their medications to come in. And then we started bringing some people back from furlough to be able to pick up that work. And then we started developing that whole community health worker program that really now supports what we call Back to Care initiative, where people are called back all the time because they've missed their appointments, because they haven't been seen. So that was a change that we had to implement in order to reach out to our patients and make sure they were getting the right care, but it's something that we've kept in. The other piece is telehealth. So we didn't know I don't think anybody knew anything about telehealth, and in 2 weeks the whole world knew about telehealth, right? And so, and a lot of the older people, the video is like out the door, right? So it was telephone appointments, telephone calls, and that's something that we all have to advocate for, because a lot of government officials do not want to pay for telehealth visits, and it's really discriminatory against especially our elder. It's just like not acceptable. It would be one of those structural racist things that they put out there. So, but telehealth was great, and we've been able to keep it in place, and it's something that if we didn't have the pandemic, we would never have gotten. Along with that, we also did some remote patient monitoring. So we were able to put blood pressure units in the homes so that people didn't have to come out and be able to monitor them that way. And the last thing we did was we started doing medical home visits. And we did them because a lot of the patients were homebound and they couldn't come into the health center. So we said, you know what, we have to reach our patients. Let's send people out. And those 4 things really, I think, have changed how we've provided care for our older adults, and I think it's improved the care. The last thing I would say is that we are applying for a PACE program, because what the PACE program showed us, because of the way they get paid, you get paid a certain amount of money, and how you use that money is up to you. So you want to buy that air conditioner, go right ahead, buy the air conditioner. And so it's not dependent on a visit. And if we would have been paid like that throughout the pandemic, we wouldn't have had any problems, because you get paid for the people who are enrolled with you versus getting paid per visit. So I think that all of that, when you put it all together and you think about it strategically, there were lots of things that the pandemic taught us to make changes that were really for the best.
Paloma, for ending on the bold policy note, and I'm sure there's much more to ask and talk about, and so we'll move on to Q&A. I think we may have time for, do we have time for one question? Yeah, we have a question back there.
For home health services, with also recognizing that they have a 28% profit margin compared to, according to MedPAC. So how do we compare the need and utility of home health services and the amount of fraud, waste, and abuse we see and their profit margins?
Can you reframe the question in terms of what you want to be
so
balanced?
I think that home health is really important, but we see a lot of fraud, waste, and abuse in home health services. So how do we reconcile those 2 things?
How how do we reconcile the instances of abuse and that, is that what you said?
Like oversight from like a government perspective and saying, how are we getting the absolute value while also increasing health outcomes?
I mean, listen, that's tough. We happen in our PACE program, in-home support services is a part of the service delivery. That is something that we do. We found that we do utilize a lot of paid family caregivers. And even in those cases, we've had to call APS, and file those sorts of reports. Again, I think it's about knowing your participant, your patient, knowing what their needs are. There are, routine and, regular reviews that have to happen in relation to the care that's supposed to be provided in the home that's assigned. There's a very prescriptive care plans, at least through our program, that's done. And, the way we monitor it is that we have home care coordinators that make unannounced visits. They do planned visits. They meet with the families. They meet with the participants. Participants are always number one. How's it going? How's it feeling? Are they doing what what's supposed to be done? And, that's all you can do. I don't think it's a problem that we'll be able to solve per se. There are going to be bad players out there no matter what. But I think, working with family caregivers to train them and give them the skills to be able to take care of their loved ones and possibly even take care of others is one way, because they're invested more in a personal way.
One thing we know for sure is that people want to, what we call age in place. They want to stay home. They don't want to, especially what we saw after COVID-19, they're not inclined to go to a nursing home.
Right.
So if they can stay home, they want to be able to utilize resources in order to do that. But it is a little bit of a changing dynamic in terms of what resources and what care providers are providing. But that's definitely what we're seeing. And so we want to be able to help facilitate that and make that happen.
I think at the end, it's a matter of oversight by whoever is the payer, whether it's the government, whether it's a private entity. You gotta have oversight over those services. And the other thing is surveys. You go out, you reach out to the recipient of the service and ask them, whether they're satisfied, whether they got what they were billed or what the payer was billed. Those are the usual, and by the way, it's not just to home health. That's usually, and it's customary to other sort of services as well.
Yeah, and
I'm sorry.
I think there's also signs, like is the patient losing weight, is the patient bruised when they come in? If you're doing home visits, is there food in the refrigerator? Like, there's a lot of signs you could get from a patient, from a person, that gives you hints of, but home care, I know in PACE, at least in New York, the biggest cost in the PACE program.
That's right.
Home care.
It sure is. It sure is. And I think there has to be an investment in education and support of the caregivers, whether they're paid or not, like we were talking about, because sometimes it's just someone not knowing what to do. They don't know they're doing the wrong thing. They don't know they're pulling mom the wrong way. That might cause, you know what I mean? So there's got to be an investment in terms of caregiver support and education in an ongoing way as well.
Good afternoon, everyone. Thank you so much, panelists, for this really important conversation that, quite frankly, doesn't get enough attention, I think. And as we've heard, it's a really critical topic. And there are resources, thank heavens, to hear to help us navigate this. And so please do help disseminate information about this topic and really all of the topics today to your colleagues, so that they can take advantage of those resources, so that we can bring about those policy changes, so that we can all take action to try and improve the well-being of our community and, frankly, of the nation. As a reminder, as was mentioned, this session and all of our sessions have been recorded, and they will be made available online within a week or two, so then you'll be able to share links with your colleagues also, and encourage them that if they didn't make it to join us here in person today, they can still take advantage of all the really important information that was shared. I want to thank our sponsors once again for their generous support and their commitment to CHCI, both today and throughout the year, helping us advance our mission. I want to thank our speakers and moderators, both this session's closing plenary and all throughout the day, for leading such insightful, engaging, and critical conversations. I want to thank our board and our advisory council members for their continued leadership and support, Our CHCI fellows, thank you for believing in both our work and your own potential and giving 9 months of your lives here in Washington. And to our CHCI alumni, I want to thank you for continuing to set an example for all of us to follow. I want to thank each of you for furthering our mission to developing the next generation of Latino leaders. Now, before we close out and we head over to our closing reception, I want to share some exciting news about our upcoming events and announcements. We hope that you can join us on Sunday, June 11th, for CHCI's second annual 5K Run to Lead. You can run it or walk it. There will be fun for the kids who join us as well, so please make time, those of you here in Washington, D.C., to come out and join us. And if you weren't already aware, this year's Hispanic Heritage Month events, CHCI's signature activities, will once again be held at the Washington Convention Center here in Washington, D.C. Our leadership conference is scheduled for September 19th and 20th, and our 46th annual awards gala is scheduled for September 21st. That's a Thursday. We are releasing season 3 of our Here to Lead podcast on May 23rd. We have 6 new episodes with 6 fascinating guests, such as our chairman, Congressman Adriano Espaillat, CHCI alumna and entrepreneur Stephanie Valencia, and CBS political director Finn Gomez. You can find the Here to Lead podcast on all your major podcast and streaming platforms, so we hope you'll subscribe and listen. All right, that's enough of the commercials. Remember that you can continue to stay in touch with us on social media and extend this conversation even further by using the hashtag CHCI Summit, and you can always find us with our handles at CHCI. That's on Facebook, Twitter, and LinkedIn, and at CHCI DC on Instagram. And finally, I want to extend a heartfelt thank you to all of my colleagues on the CHCI team. That includes our full-time staff and our contractors and vendors who are basically like family because they literally spend every day and many holidays with us. So we're really grateful for your tireless work in helping to put together an event like this, which we think has been incredibly successful. And I want to thank once again each of you, not just for being here today, but for all that you do for our community each and every day, because that's what helps us to become a stronger community and a better nation. So now, please join us in the reception, and thank you very much for being here.